Ablation for atrial fibrillation. Atrial fibrillation, AF, affects approximately 37.6 million people worldwide, with a prevalence of 0.5% to 1% in the general population, increasing to 9% in those over 80 years old. The pathophysiological mechanism involves electrical remodeling and fibrosis in the atria, leading to irregular heart rhythms. Key diagnostic approaches include electrocardiogram, ECG, and echocardiography, with a primary management strategy focusing on rhythm or rate control, and anticoagulation to prevent stroke. Pulmonary vein isolation, PVI, via ablation is a crucial treatment for symptomatic AF, with success rates ranging from 50% to 80% after a single procedure. Key points. Note: atrial fibrillation, AF, prevalence increases with age, affecting 9% of individuals over 80 years old. The CHA2DS2 VSC score is used to assess stroke risk, with scores greater than or equal to 2 indicating anticoagulation therapy, and a score of 0 indicating a 0% annual stroke risk. Pulmonary vein isolation, PVI, is recommended for symptomatic AF patients who have failed or cannot tolerate antiarrhythmic medication, with a success rate of 50 to 80% after a single procedure. Warfarin dose is adjusted to maintain an INR between 2.0 and 3.0, with a target INR of 2.5. The Has-Bled score is used to assess bleeding risk, with scores greater than or equal to 3 indicating a high risk of bleeding, and a score of 0 indicating a low risk. Ablation procedures can be performed using radiofrequency, RF, or cryoablation, with RF ablation having a success rate of 70 to 80% and cryoablation having a success rate of 60 to 70%. The duration of anticoagulation therapy after ablation is typically 2 to 3 months, with a minimum of 2 months of warfarin therapy. The European Society of Cardiology, ESC, recommends PVI as a first-line treatment for symptomatic AF, with a Class I indication. The American Heart Association, AHA, recommends the use of antiarrhythmic medication as a first-line treatment for AF, with a Class I indication. The dose of flecainide for AF is 50 to 150 mg twice daily, with a maximum dose of 300 mg per day. Overview and epidemiology. Atrial fibrillation, AF, is a supraventricular tachyarrhythmia characterized by rapid and irregular atrial impulses, resulting in a rapid and irregular ventricular response. The global prevalence of AF is estimated to be around 37.6 million people, with a prevalence of 0.5% to 1% in the general population, increasing to 9% in those over 80 years old. The incidence of AF increases with age, with a median age of 75 years at diagnosis. The economic burden of AF is significant, with estimated annual costs ranging from $6,000 to $10,000 per patient. Major modifiable risk factors for AF include hypertension, relative risk 1.5, diabetes mellitus, relative risk 1.3, and obesity, relative risk 1.2. Non-modifiable risk factors include age, male sex, and family history of AF. Pathophysiology. The pathophysiological mechanism of AF involves electrical remodeling and fibrosis in the atria, leading to irregular heart rhythms. The process is initiated by triggers such as ectopic beats, which can originate from the pulmonary veins or other areas of the atria. The triggers interact with a susceptible substrate, including areas of fibrosis and electrical remodeling, to maintain the arrhythmia. Genetic factors, such as mutations in the KCNQ1 and KCNH2 genes, can also contribute to the development of AF. The disease progression timeline typically involves a period of paroxysmal AF, followed by persistent and then permanent AF. Biomarkers such as brain natriuretic peptide, BNP, and troponin can be elevated in AF, and are associated with an increased risk of stroke and mortality. Clinical presentation. The classic presentation of AF includes symptoms such as palpitations, 80%, shortness of breath, 60%, and fatigue, 50%. Atypical presentations, especially in the elderly, diabetics, and immunocompromised, can include symptoms such as confusion, syncope, and chest pain. Physical examination findings can include an irregular pulse, with a sensitivity of 95% and specificity of 90%. Red flags requiring immediate action include symptoms such as chest pain, syncope, and shortness of breath, which can indicate underlying cardiac or pulmonary disease. Symptom severity scoring systems, such as the European Heart Rhythm Association (EHRA) score, can be used to assess the severity of symptoms and guide treatment. Diagnosis. The diagnosis of AF is typically made using a 12-lead electrocardiogram (ECG), which shows an irregular rhythm with no discernible P waves. Laboratory workup can include tests such as complete blood count (CBC), basic metabolic panel (BMP), and thyroid function tests (TFTs), with reference ranges including a white blood cell count of 4,500 to 11,000 cells/μl, a serum creatinine of 0.6 to 1.2 mg/dl, and a thyroid stimulating hormone (TSH) level of 0.4 to 4.5 μu/ml. Imaging modalities such as echocardiography and cardiac computed tomography (CT) can be used to assess cardiac structure and function, with findings such as left atrial enlargement and left ventricular dysfunction indicating an increased risk of stroke and mortality. Validated scoring systems, such as the CHA2DS2 VSC score, can be used to assess stroke risk, with scores greater than or equal to 2 indicating anticoagulation therapy. Management and treatment. Emergency stabilization of AF typically involves rate control using medications such as beta blockers, e.g. metoprolol 25 to 50 mg 4, or calcium channel blockers, e.g. diltiazem 20 to 50 mg 4. Monitoring parameters can include heart rate, blood pressure, and oxygen saturation, with immediate interventions including cardioversion for patients with severe symptoms or hemodynamic instability. First-line pharmacotherapy for AF typically involves the use of antiarrhythmic medications such as flecainide, 50 to 150 mg twice daily, or propafenone, 150 to 300 mg twice daily. The mechanism of action of these medications involves blocking sodium channels and prolonging the atrial refractory period. Expected response timeline can include a reduction in symptoms within 1 to 2 weeks, with monitoring parameters including ECG, blood pressure, and liver function tests, LFTs. Evidence base for the use of antiarrhythmic medications includes trials such as the AFFIRM study, which showed a reduction in symptoms and improvement in quality of life with the use of antiarrhythmic medication. Key points: pregnancy, safety category C. Preferred agents include digoxin 0.125 to 0.25 mg twice daily, and beta blockers, e.g. metoprolol 25 to 50 mg twice daily, with dose adjustments based on clinical response and fetal monitoring. Chronic kidney disease. GFR-based dose adjustments can include a reduction in dose of 25 to 50% for patients with a GFR less than 30 ml per minute, with contraindications including the use of medications such as metformin in patients with a GFR less than 30 ml per minute. Hepatic impairment. Child-Pugh adjustments can include a reduction in dose of 25 to 50% for patients with Child-Pugh class B or C liver disease, with contraindications including the use of medications such as amiodarone in patients with Child-Pugh class C liver disease. Elderly. Greater than 65 years dose reductions can include a reduction in dose of 25 to 50% for patients over 75 years old, with Beers criteria considerations including complications and prognosis. Major complications of AF can include stroke, incidence 4.8% per year, heart failure, incidence 10.6% per year, and mortality, incidence 6.8% per year. Mortality data can include a 30-day mortality rate of 1.3%, a 1-year mortality rate of 10.6%, and a 5-year mortality rate of 30.8%. Prognostic scoring systems, such as the CHA2DS2 VSC score, can be used to assess stroke risk, with scores greater than or equal to 2 indicating anticoagulation therapy. Factors associated with poor outcome can include age, hypertension, and heart failure, with ICU admission criteria including symptoms such as chest pain, syncope, and shortness of breath. Recent advances and emerging therapies, 2020 to 2024. New drug approvals can include the use of medications such as edoxaban, 60 mg once daily, and apixaban, 5 mg twice daily, for stroke prevention in AF. Updated guidelines can include the 2020 ESC guidelines, which recommend the use of catheter ablation as a first-line treatment for symptomatic AF. Ongoing clinical trials can include the NCT 04242155 trial, which is evaluating the efficacy and safety of catheter ablation in patients with AF. Patient education and counseling. Key messages for patients can include the importance of adherence to medication, with a target adherence rate of 80%. Medication adherence strategies can include the use of pillboxes and reminders, with warning signs requiring immediate medical attention including symptoms such as chest pain, syncope, and shortness of breath. Lifestyle modification targets can include a reduction in sodium intake to less than 2,300 mg per day, with follow-up schedule recommendations including regular follow-up with a healthcare provider every 3 to 6 months. Clinical pearls. Note: the use of antiarrhythmic medication can reduce symptoms and improve quality of life in patients with AF, with a success rate of 50 to 80% after a single procedure. Catheter ablation is a highly effective treatment for symptomatic AF, with a success rate of 50 to 80% after a single procedure. The CHA2DS2 VASC score is a useful tool for assessing stroke risk in patients with AF, with scores greater than or equal to 2 indicating anticoagulation therapy. The use of warfarin can reduce the risk of stroke in patients with AF, with a target INR of 2.5. The HAS-BLED score is a useful tool for assessing bleeding risk in patients with AF, with scores greater than or equal to 3 indicating a high risk of bleeding. The European Society of Cardiology, ESC, recommends the use of catheter ablation as a first-line treatment for symptomatic AF, with a Class I indication. The American Heart Association, AHA, recommends the use of antiarrhythmic medication as a first-line treatment for AF, with a Class I indication. The dose of flecainide for AF is 50 to 150 mg twice daily, with a maximum dose of 300 mg per day. The use of edoxaban and apixaban can reduce the risk of stroke in patients with AF, with a success rate of 80 to 90% after a single procedure. References: 1. Joglar J.A. et al. 2023 ACC/AHA/ACCP/HRS Guideline for the Diagnosis and Management of Atrial Fibrillation. A report of the American College of Cardiology/American Heart Association Joint Committee on Clinical Practice Guidelines. Circulation. 2024, 149, 1E1E156. PMID, 380333089. https://pubmed.ncbi.nlm.nih.gov/380333089. doi 10.1161/CIR.0000000000001193. 2. Reddy v.Y. et al. Pulsed field or conventional thermal ablation for paroxysmal atrial fibrillation. The New England Journal of Medicine. 2023, 389, 181660-1671. PMID, 376344148, https://pubmed.ncbi.nlm.nih.gov/376344148. DOI 10.1056/NEJMOA 2307291. 3. Reichland T. et al. Pulsed field or cryoballoon ablation for paroxysmal atrial fibrillation. The New England Journal of Medicine. 2025, 392, 151497-1507. PMID, 4016274, https://pubmed.ncbi.nlm.nih.gov/40162734. DOI 10.1056/NEJMOA 2502280. 4. Reddy v.Y. et al. Pulsed field ablation to treat paroxysmal atrial fibrillation, safety and effectiveness in the ADMIRE pivotal trial. Circulation. 2024, 150, 151174-1186. PMID 392583362. https://pubmed.ncbi.nlm.nih.gov/392583362. DOI 10.1161/circulation/AHA.124.070333. 5. Reddy v.Y. et al. Pulsed field ablation of persistent atrial fibrillation with continuous electrocardiographic monitoring follow-up, Advantage AF Phase 2. Circulation. 2025, 152, 127-40. PMID 40273320. https://pubmed.ncbi.nlm.nih.gov/40273320. DOI 10.1161/circulation/AHA.125.074485. 6. De Campos MCAV et al. Pulsed field ablation versus thermal ablation for atrial fibrillation, a meta-analysis. Heart Rhythm 02. 2024, 5, 6385-395. PMID 389843363. https://pubmed.ncbi.nlm.nih.gov/389843363. DOI 10.1016/J.Ru.2024.04.012. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.